My name is Ron Myers. I'm the Director of Editorial here at JoVE. And so today we have a webinar with Jeannine Kümin. So her group has published with us multiple times in the past, and particularly on sidewall aneurysm models. And these articles were very well received, so we wanted to host a webinar on any recent updates and modifications to the procedure that have happened in recent years. So we will take questions at the end of the webinar, and we'll also send out a follow-up email afterwards with a recording of the webinar, so you'll have that for your records. And feel free to follow up with any questions you may have at that point as well. All right, so I will leave it to Jeannine.
Thank you very much, Ron. And hello, everybody. Now I will try to share my screen. So I think now everybody should see my screen. Thank you very much, Joe, for having me here today for this webinar about the microsurgical sidewall aneurysm model. As you mentioned correctly, we work with this model for many years. So my chief, Professor Marbacher, started with these experiments in 2012 already in Helsinki. So that's the reason why the first video about it was called the Helsinki Sidewall Aneurysm model. But since then, we've done quite a lot of modification to the model itself. And I would like to present some of them to you in the next few minutes. So we will start with a short abstract, then I will shortly present to you the original model before we come to all the modification with coil application, stent application, BioEmbolisation treatments, and also the application of intraluminal substances, as well as the fluorescence imaging at the end. As you probably all know, the rupture of saccular cerebral artery aneurysm causes stroke, permanent neurological damage, or even the death of the patient. And so far, the only treatment for preventing the rupture of intracranial aneurysm is open surgery or endovascular treatment. Therefore, we need some experimental models to study the healing mechanisms and to test novel endovascular devices. So the aim of my group and all these experiments I will present to you in a few minutes is to create a simple, robust, and inexpensive experimental model with a high level of standardization. We worked with different kinds of rats. So we had Wistar or Lewis rats with a minimal age of 8 weeks and a weight of minimum 200 grams or 500 grams if they were used for standing. The animals were housed according to institutional guidelines with free access to tap water and pellet diet, and all animals were allowed an acclimatization of at least 1 week prior to surgery. To start with the graft harvest, we used saccular aneurysm, which are created from the descending aorta of a donor rat. Therefore, under general anesthesia, we opened the thoracic cavity. Then the animal was sacrificed with endocardial overdose of ketamine hydrochloride before a ligature was placed just above the first intercostal artery. Like this, we could create very standardized aneurysms with a width of 2.5 to 3.5 millimeters, depending on sex and age of the animal, and a length of around 4 millimeters. These aneurysms were then either transplanted directly into the recipient rat as vital aneurysms, or they underwent a decellularization process prior to implantation. The vital aneurysms, which were implanted directly after harvesting, they have a vital and cell-rich aneurysm wall, whereas the decellularized aneurysm, which underwent a chemical decellularization process with 0.1% sodium dodecylsulfate sulfate prior to implantation, have a wall without any vital cells, which makes them, as we have seen in our results, more prone to grow and eventually even rupture. So we have here a comparison between highly degenerated rupture-prone aneurysm walls in the decellularized group versus quite a healthy and vital aneurysm wall in the vital directly transplanted group. On the bottom line, you see some pictures from a baseline and follow-up of an aneurysm with a decellularized wall, where we see a massive increasement of the size, as well as on the right side we have the histological picture of a decellularized aneurysm with a massive growth over only 3 weeks. Then let's talk about the aneurysm creation. The animals were all under general anesthesia with continuous monitoring of the vital signs and temperature control. Then a midline incision was performed below 1 centimeter below the xiphoid process. Then the abdominal aorta was dissected between the renal vein and the lumbar arteries, and a colored rubber pad was placed below the artery to enhance contrast, as well as to protect the underlying structures, as for example, the vena cava or the nerve plexus. Then temporary clipping was performed before we did an end-to-side anastomosis to create the sidewall aneurysm with 9-0 or 10-0 non-absorbable sutures. Depending on the treatment modality, treatment was performed either before, during, or after suture, but more about this in a few minutes. And for the results, it's quite a fast surgery with a learning curve, but at the end, the surgery time was around 45 minutes with a suture time of around 9 minutes and a very low mortality rate of below 5%. As you have probably seen when you've watched some of our videos, there's no need of sophisticated materials. So all the instruments you see on these 2 pictures are enough. And if you are more limited, you even don't need the microneedle holder or the micro forceps, which is curved here on the top left. So it's really without any sophisticated materials. And there is no need of assistance. So one researcher can perform the surgery and anesthesia all in its own. And the aneurysm model is really standardized regarding size, shape, and localization of the aneurysm. This makes it suitable for different endoluminal and endovascular treatments. So let's now talk about the modifications we did over the last 10 years. The probably biggest change was the anesthesia. We started about 10 years ago with intraperitoneal anesthesia with medetomidine and ketamine, which gives us approximative surgery time of about 45 to 60 minutes. But since the procedures got a bit more complex with all the modifications, we had to change the medication to a mixture of fentanyl, medetomidine, and midazolam, and added isoflurane for longer procedures. This has the benefit that we can reverse the anesthesia by the end of the surgery. And therefore, we used a mixture of buprenorphine, atipomazole, and fluorescence. And we also started to use a heating pad and continuous monitoring of the vital signs to have a better control over the anesthesia death, as well as for a faster and better postoperative recovery of the animals. The first modification, which is quite simple, which we did to our aneurysm model, was the use of detachable coils, which were inserted at the end of the aneurysm creation. As you can see here in the left picture, right before closing the end-to-side anastomosis, so there's only 1 stitch missing, we inserted the microcatheter with the coil inside the aneurysm dome and then applied 3 to 4 centimeters of these detachable coils. When we have done a look at the results, we see that in vital aneurysm, there was quite a good healing rate with complete coverage of the aneurysm dome and the coil with an neointima, whereas in the decellularized group, we had not a really good neointima formation with a rather high rate of recanalizations. This led us to the next experiment with the magnesium stent. Unfortunately, these stents are quite big, so they have a diameter of around 3 millimeters when they are fully expanded. So we were limited to bigger animals with a weight of at least 500 grams. Then the aneurysm was created between the renal vein and the iliolumbar arteries, as previously described. It's here segment 2 in this picture on the right. But since we have to insert the stent with its guide wire and all the stuff around, we needed a much longer dissection. So we dissected the abdominal aorta from the renal vein all the way down to the iliacarp bifurcation. Then we placed 2 clips, one in the very distal segment right above the iliolumbar bifurcation, iliacal bifurcation, and the other one at the very top of the surgery field, right above the renal vein. Then the arteriotomy was performed right cranial to the distal clip, and the stent was inserted in Seldinger technique, and we, under visual control, we could place it right below the aneurysm. One of the big benefits by inserting the stent through the abdominal aorta is that no vessels need to be sacrificed, and that you have a visual control of placement. So there were no misplacements during our experiments. And we have seen in the histological and microscopic analysis that we have an improved neointima formation, which is probably facilitated by cell migration over the stent struts. And we have a benefit of the combination of different endoluminal embolization materials, which can be used together with the stents, such as BioEmbolisation materials or also coil treatment. The disadvantages of this model is that the surgery time is much longer than in the standard model, since we have much longer dissecting the distance from the renal vein all the way down to the iliacal bifurcation. So the surgery time was around 2 hours for this procedure. It was limited to bigger rats, so around 500 grams. And there was a risk of instant thrombosis or stenosis because we didn't treat the rats with antiplatelet therapy after the surgery. One of the materials we used together with the stent, but also on their own, was the BioEmbolisation material. We had tested 2 different threads. We took 0.5 centimeter of each thread. We had a short and a long lasting one, and they were then separated into their single fibers and formed as a little cloud, which could be inserted into the aneurysm dome. So here on the top right, we have this little cloud, which is then inserted into the aneurysm dome, and which is capable to soak up to 5 microliters of fluid, which makes it a good carrier for further experiments and testing of different substances, which should be implemented or injected into the aneurysm dome for better healing. Here again, some histological pictures where we see a nice neointima formation over the aneurysm orifice with a complete coverage of the BioEmbolisation material. As I've already mentioned, this BioEmbolisation material, we've then further worked with the short-lasting thread, is a good carrier material for intraluminal substance application. Our most recent experiments were with FGF2, which was diluted and then injected into this little cloud. So we had a soaked cloud of FGF and BioEmbolisation material inside the aneurysm dome with the aim to improve neointima formation. Another substance which can be used as carrier medium is the fibrin polymer. Professor Marbacher has a study from 2014, which was published in Stroke, where he injected cmDil levels of muscle cells into a fibrin polymer right into the aneurysm dome prior to surgery. This was also tested to see if it improves the neointima formation and healing of the aneurysms. Another kind of injection, not into the aneurysm, but into the parent artery, is the cmDil dye. A cmDil is a dye that labels endothelial cells in the adjacent vessel to track their proliferation. So after standard procedure with clamping and dissecting the aorta, we injected the cmDil dye into the parent artery with a very small catheter or a small needle. And then after 15 minutes of incubation, we finished the surgery as previously described. For the results, here we have also seen that cells from the neointima or forming the neointima originate either from the parent artery, so our cmDil labeled cells, but there are also cells which are probably coming from the system itself, or sometimes even from the aneurysm dome in vital aneurysms. This leads us to the topographic distribution of cells inside the aneurysm dome, but also in the neointima formation. There are different techniques how to assess the topographic cell distribution and the healing mechanisms. The most easy one is to work with transgenic rats. So we've worked with GFP positive and GFP negative animals. where we have transplanted GFP positive vital aneurysms to GFP negative rats and the other way around to see where the cells forming the neointima are coming from. And here as well, we have seen that in cell-rich vital aneurysms, the cell forming the neointima are also cells which derive from the aneurysm wall. So vital aneurysm walls can probably help to form a better and more intact aneurysm neointima with aneurysm occlusion. The other way, as we already described, was the cmDil dye. And last but not least, we have the immunohistological stainings, which can be used either for soluble factors or also for immune cells to see the distribution within the aneurysm dome, but also inside the aneurysm neointima or the aneurysm walls. And the last topic I would like to talk about is the fluorescence video angiography. It's a really simple technique which can be used with all the other modification I described before. So there we have both online bandpass filter and used together with fluorescein 10%, which was applied through the femoral vein, either after aneurysm creation or at the end point where we had the follow-up after several weeks. This was used to assess the parent artery patency, as well as the aneurysm recurrence after creation, as well as after treatment at the follow-up time points. And as you can see on these pictures, on the left side, we have the microscope view, and picture B shows us the aneurysm directly after creation, where we have a nice fluorescence of the parent artery as well as of the aneurysm itself. So there was no thrombus inside the aneurysm at this time point. And then when we have a second look at it after a few weeks, we have in picture C a partial recurrence of the aneurysm, where we have a fluorescence signal at the bottom of the aneurysm dome, but no signal at the top. And in the last picture, we have a complete exclusion of the aneurysm from the circulatory system. So this was associated with a complete neointima formation in the microscopic and histological analysis. To conclude, we have here a very fast and consistent method to create standardized experimental aneurysms to the parent artery, which makes us gives us the possibility to test for different endovascular and endoluminal therapies and devices. And we also have the possibility to test aneurysms with different wall conditions to evaluate the natural course of aneurysm healing in rupture-prone decellularized aneurysm compared to relatively vital and healthy aneurysms. And the model allows for the endoluminal application of different medications and substances to analyze cell migration, aneurysm healing, as well as topographic distribution of the cells inside the aneurysm dome to thrombus and also to neointima. As we've said at the beginning, the standard model has a very low rate of morbidity and mortality of below 5%. It increased a little bit with the stent because the stent is quite big and there was the risk of rupture or in-stent stenosis. But all in all, we have a fast and reproducible model without the need of any sophisticated materials. And if you're interested in and have not done so far, we have quite a lot of videos on JoVE about our standard procedure as well as the modifications. And if you are further interested, you could follow us on Twitter or ResearchGate, where we have all our publication about the results of these models and modifications. Now, thank you very much for your attention and feel free to ask questions. I see there's one question from Maria. Yeah, it's quite complicated for smaller vessels to test this model. We've only worked with the abdominal aorta of the rats so far. They have about the same size as the human medial cerebral artery, so it's around 2 to 2.5 millimeters in diameter. If you have younger animals or female animals, the vessel is sometimes a little bit smaller. So the smallest animals we've worked with were females at the age of 8 weeks. They were around 180 to 200 grams, and the aorta was then around 1.5 to 2 millimeters. But we've not worked with smaller aneurysms so far.
Okay, so I think that's all the questions, unless any others pop up here. Like I was saying before, we did record the webinar, so we'll send you guys out a email later today with the recording. And if you have any other follow-up questions, you can respond to that email, and you know, we can help you with any requests you may have. All right. Well, thanks again, Jeannine, for the great presentation, and thank you to all the attendees. And yeah, we'll send you an email later today.
Thank you very much.
Thanks, everyone. Bye-bye.